Sebaceous carcinoma, although fairly uncommon, is probably one of the more frequently encountered malignant appendage tumors. And it's particularly important because, generally speaking, it's a high-grade tumor. And if you're able to get an early biopsy and recognize it promptly, then the patient has a chance of surgery with a complete excision. But if you miss the diagnosis, it's pretty disastrous. Now, the image on the left it has got quite a history. This goes back to when I was training in in pathology in Belfast at the Royal Victoria Hospital. And this was the very first extraocular sebaceous carcinoma that I encountered in this very elderly lady. That's way over 50 years ago, so that's quite a treasured image. Now, it used to be, and when I was training, it was always taught that you should divide these into periocular and extraocular tumors. But the modern literature suggests that that's not really appropriate, and that they basically should all be regarded as one and the same thing. The only difference, I suppose, is Muir-Torre syndrome is more often associated with extraocular lesions, but even that's questioned by some authors. Now, mostly they occur around the eye from any of the pre-existent sebaceous glands. Most commonly the meibomian gland, but it can arise from the tarsal sebaceous glands and so on. And then the extraocular lesions mostly are on the head and neck, but you can get them just about anywhere on hair-bearing skin. And the interesting thing is you can also get them at non-cutaneous sites, including the oral cavity and palate. You can get them in the salivary gland, particularly the parotid gland. You can get them in the bronchus and in the cervix. And I've not seen it, but it's been described as arising in an ovarian dermoid tumor, which would be quite a finding. And sebaceous carcinoma is one of the tumors that may be associated with mutations in the mismatch repair genes and Muir-Torre syndrome. And that's an important thing to always check when you have a patient with sebaceous carcinoma. And on the right, I've got a nice image that was shared by Health Jade, showing it's rather deceptive on this image, but you can see there's some ulceration, and then there's swelling going on towards the nasal side of the eyelid. So that's a periocular one, and there's another one presenting, and this one's courtesy of the Mayo Clinic, and it's presenting as quite a large swelling involving most of the upper eyelid. And then on the right, and this is another treasure slide of mine, this was the very first sebaceous carcinoma that I encountered arising away from the head and neck, and this presented on abdominal skin, but those sites are very, very exceptional. Now, the etiology and pathogenesis of sebaceous carcinoma, there's not an awful lot known about it. Ultraviolet light is thought to have some effect. And in Asian communities, HIV has been shown to be of some importance, although I'm not sure whether that's generally accepted. And one can see, and I suppose this goes along with UVB, one can see P53 mutation and CRB2 expression can be accentuated, and that's said to be associated with a poor prognosis. Now, most tumors are not associated with an epidermal origin, but sometimes you may see it, particularly in the periocular lesions. And again, pagetoid spread is a feature of periocular lesions, but you don't see it in the not in the extraocular sebaceous carcinomas. And this is on the right. This is a lesion from the eyelid, and you can see nodules of sebaceous carcinoma with involvement of the overlying epithelium. And this is really one of the most important points, is when you get a biopsy from the eyelid, it's very important when you're thinking of terms of Bowen's disease that you look very carefully, and you might even want to do immunohistochemistry to make sure that you're not actually dealing with in situ sebaceous carcinoma. I've certainly seen quite a few cases over the years where it would have been very easy to have mistaken the epithelial lesion as Bowen's disease. And the thing about sebaceous carcinoma, which differentiates it from any other sebaceous tumors, is that generally speaking, the sebocytes are very much reduced in number. Sometimes they're extremely hard to find, and basaloid cells predominate. As you can see on this image on the right, I mean, you'd be hard pushed to call that a sebaceous carcinoma. You might notice that there are conspicuous mitotic figures, but that would be a very difficult diagnosis. Sometimes you get a lot of necrosis, and occasionally this looks a bit comedo-like, and that's been isolated as a particular variant, although I'm not sure that serves any great purpose. Now, the histology in terms of pleomorphism varies quite a bit. Some tumors are not so pleomorphic, whereas others can be almost anaplastic and very difficult to diagnose. And I'm going to show you a few cases to illustrate those features. Bad news for any patient that shows perineural infiltration or lymphovascular invasion, because that's very much associated with a poor prognosis. And then occasionally you can get a ripple pattern, which can be confusing until you find the sebaceous differentiation in the form of sebocytes. So here's a lovely case. This is from the eyelid, and you can see very obvious large expansile nodules in the underlying tissues. And I think even at this magnification, you can make out vacuolation, which would raise the possibility of a sebaceous tumor, or you might wonder about a clear cell tumor of some sort, carcinoma or hydradenocarcinoma. And there's overlying Paget's disease shown on high power on the right. And this is sort of the classic problem case where you can come very unstuck if you don't look at it carefully enough. And there's on the left you can see the pagetoid spread, and on the right I think one can begin to pick up that there is sebaceous differentiation, particularly in the right upper quadrant of that image. But I'll show you, here's another. This is deeper down just to show you how extensive the tumor is. And there's a lot of necrosis. Now, it's quite interesting. when you don't have really well developed sebocytes, you can end up thinking these are clear cells, and so you might be trapped into thinking this was one of the differential diagnoses, like, for example, clear cell hidradenocarcinoma or balloon cell melanoma. And this is an interesting feature which can catch the unwary. There you see on top left of the field, there are well-formed sebocytes with multivacculated cytoplasm. So when you look there, it's pretty obvious that it's a sebaceous carcinoma. Lots of mitotic figures. There are at least three mitoses, and you can see a bit of apoptosis as well. And on the right, these are actually histiocytes, which are just been ingesting lipid that's been broken down from the necrosis of an adjacent tumor. But on its own, you might find that very, very confusing. And there's a close-up view there showing mitotic activity, nuclear pleomorphism, very marked pleomorphism, prominent eosinophilic nucleoli, and not such well-developed sebocytes in that field. And again, this is another field showing much the same thing with conspicuous mitotic activity and focal apoptosis. And then after due diligence and much searching, there is the perfect sebocyte with a sort of a crenulated nucleus and then multiple intracytoplasmic vacuoles. That is the most perfect sebocyte in a sebaceous carcinoma you could ever ask for. So keep that in mind when you're next looking at this sort of tumor. And this field, what does this show? It shows lots of apoptosis and well, that's about it. Lots of and I suppose that there is nuclear pleomorphism and prominent nucleoli, and there is a field showing a tripolar mitotic figure. So that's a really good sebaceous carcinoma. Now, some people believe in grading them, these tumors, and others don't, and I tend to report them mostly as sebaceous carcinoma, but if I was going to grade this one, I think it would be very much high grade, and I'd be very concerned for the patient. And then at the other end of the spectrum, one has this sort of a tumor where the degree of pleomorphism is much less, although sebocytes are very, very scanty. Most of the tumor is composed of basaloid germinative cells. And there's a close-up view there where there is a bit more obvious sebocyte formation, and a close-up view showing lots and lots of mitotic figures, 1, 2, 3, 4, 5, 6, 7 or more mitoses, significant pleomorphism, and very prominent nucleoli, so it's easy to recognize that as a sebaceous carcinoma. And then this is a lovely one that Antonina Kalmykova shared with me, and I think it came from well, it is extra ocular. I'm not quite sure where the site was. Perhaps it was from the abdomen. Anyway, it's a gigantic tumor, absolutely gigantic, and you can see at the top in the right-hand quadrant that it's ulcerated, and there's lots and lots of necrosis. In fact, most of the tumor is necrotic. And there's a close-up or a closer view there showing extensive tumor necrosis. And on high power, there aren't so many SIBO This is all necrotic tumor, and there are unilocular, I suppose they are, one can call them SIBO but they're not so easy to recognize. And there's a close-up view showing two mitotic figures, and elsewhere there are well-developed SIBO. I just wanted to touch on immunohistochemistry for sebaceous carcinoma because this is one of the tumors where it's quite important. This is a really old slide where I was fortunate enough to have some tissue that was not processed, and we did an oil red O on it, and we were very lucky to show that it was strikingly positive. But unfortunately, in most cases nowadays, you're not able to do that. And it's sebaceous carcinoma is strongly EMA positive, but that can be doesn't really help you too much if you had a squame, for example, that was pretending to be a sebaceous carcinoma, it would be EMA positive as well. And I think the immunoreagent adapofilin is the most useful one, as it's strongly positive in sebaceous carcinoma and it's negative in the differentials. And also androgen receptors strongly positive. And it's particularly important in the context of Muir-Torre syndrome to think about mismatch repair gene mutations, and we'll look at those now. Now, this is the case of Antonina's that I just shown you, and the patient did have Muir-Torre syndrome. There was retention of MLH1, as you see, it's a nuclear marker and it's strikingly positive. At PMS2 was basically probably negative, although one could argue there are some positive nuclei, but anyway, it's certainly diminished in expression. MSH2 was completely negative, and MSH6, again, there are some nuclei positive, but most of the tumors negative. So that was a patient who turned out to have Muir-Torre syndrome, and this is adapofilin, which is strikingly positive in the SIBO. Now, this is a really good tumor that was shared with us on McKee by Diego Morales Neira, and it's an absolute it's a great tumor because it shows you how easy it might be to misdiagnose this. Because when you look at that at low power and you see this cystic space with some basaloid cells around the edge and a few SIBO, I can see that if you weren't paying as much attention as you ought to be, that you might think that was a cystic adenoma. I think that would be quite easy to do. And there's a close-up view there, just showing you that most of the lesions cystic and necrotic, and that we're really only got a viable rim around the outside. But when we look at that rim carefully, the diagnosis becomes pretty obvious. Now there's a nice field where we've got germinative cells and lots of multivacuolated, beautiful SIBO, absolutely gorgeous. High power, however, shows significant nuclear pleomorphism, very conspicuous nucleoli, and mitoses were not difficult to find. There's one down there, for example. But there's very worrying nuclear changes. And there's a high power view showing another mitosis. Look at those nuclei. They're very, very pleomorphic. And so whilst at low power you might have wanted to call it an adenoma, as I mentioned, if you look at it carefully, you can see that this is not an adenoma. And there's that other mitosis shown in very high power view, and again emphasizing the prominence of the nucleoli. Now, I mentioned, just to go back to the low power, I mentioned grading the sebaceous carcinomas, and I think although I'm not very keen on grading most of the time. I think this one probably would be fair to say that it's probably a low grade one, and I would imagine that you know, a limited re-excision just to make sure there's nothing left would be all that you'd need, and I doubt the patient would come to any harm, although I don't have any follow-up. And that tumour showed loss of MSH2 and MSH6 predominantly, whereas PMS2 was strongly positive. And that patient also had Muir-Torre syndrome. There's MLH1, which was also present. Now, what about the differential diagnosis? I think the real issue is sebaceous adenoma, and this is largely because the late Bernie Ackerman was very enthusiastic with the idea that all sebaceous adenomas were in fact carcinomas. Now, I don't think that idea held sway for most people, and I certainly don't think that's true. And sebaceous adenoma, I think, is readily recognized. This is a gorgeous example that Gowri Priya shared with us on McKee. And this one is cystic, but you can see that the epithelium, there's a very narrow germinative layer, and then most of the tumor, 90% or more, are mature sebocytes, and we'll see that in a moment in high power. I'll touch on sebaceoma. BCC with sebaceous differentiation, which some people like to call sebaceous epithelioma, is very rare. And in any cases that I've seen a BCC with sebaceous differentiation, it's arisen in the context of nodular BCC with a well-developed palisading, retraction artifact, and so on. And you tend not to get much in the way of palisading in sebaceous carcinoma, so I don't think it should really be a problem. I mentioned Bowen's disease in the context of eyelid lesions, and if the tumors don't show decent sebocytes, then clear cell squamous and hydradenocarcinoma are certainly differentials, but neither of those tumors will express adapophyllin if you have any real problems. And lastly, balloon cell melanoma. It seems extraordinary to think of that, but sometimes you can get a balloon cell melanoma that looks awfully like a sebaceous carcinoma, and I'm going to show you one of those in a minute. So there's a close-up view of Gowri's case, and you can see that it's 99% sebocytes and only 1% germinative cells. So I think one can look at that quite happily and say that this is just a sebaceous adenoma, and there's a closer view. So I don't think anybody should look at this and go down the carcinoma pathway. I think that would be a very bad mistake. Now, sebaceoma differs from adenoma in that it's a multinodular tumor which sometimes shows an origin from the epidermis, and it has much fewer sebocytes, and these tend to be scattered around, so it's germinative cell predominant. And the other thing you see in sebaceoma commonly are ducts, sometimes with a well-developed cuticle. And this is a lovely example of sebaceoma here. And you can see in the bottom left, there's a very nice sebaceous duct curving around in that lower right quadrant. And then this is one that Carlos Cerruto shared. And again, it's a lovely tumor. It's arising from the epidermis. The sebocytes are very much limited. They're maybe 20-25% of the tumor. The rest are germinative cells, so that knocks out a diagnosis of sebaceoma, or sebaceous adenoma rather. And on the left you can see a lovely sebaceous duct going up to the surface. So that's a beautiful case. It's textbook sebaceoma. And then lastly, I wanted just to show you a case. This is a case that Antonina Kalmykova kindly shared with me, and I showed it at a meeting in Dial in Dubai. And so I'm looking at it backwards. And if you look at it backwards, what you're looking at are undifferentiated cells, many of them showing cytoplasmic vacuolation. Lots of mitoses. There are four. No, there's one, two, three. There are five annotated there, and in fact, I can see a sixth. So if you took that field on its own, that could easily be a sebaceous carcinoma in which we're not getting good germinative cells. So if we go back to a lower power, you can see this is continuation of the undifferentiated cells, and then it merges with much larger balloon cells, and there's no the cytoplasm is filled with amorphous pink granular material. There are no cytoplasmic vacuoles, no sebocytes in that field. And then we go to a different area, and here you see this is beautiful because you've got a central nucleus with a big nucleus, and these cells are very sebocyte-like because they're multivacuolated. But then you look on the right-hand side and you see melanin pigment, and you say, uh-oh, this is not a sebaceous carcinoma, this is a balloon cell melanoma. And there's the low power view there, showing undifferentiated component, balloon cell change, and along the bottom you can see a lot of pigment, and you can just about make out the in situ component in the bottom right hand quadrant. This is the most beautiful balloon cell melanoma I've ever seen, and I'm very grateful that Antonina shared it with me. It's a wonderful case. So I hope this talk has been of some use to you, and if you have any questions to ask, don't hesitate. I'd be very great. I'd be very happy to answer any questions that you might have to ask. Now I'm going to try and stop this video, which is always a problem. There.